So now in the United States, and this will be coming to Pakistan either now or in the coming years because these are such powerful new agents, although right now they're very expensive, but that will change over time. So we actually have 3 different ways to reverse immune tolerance in human cancer patients. So the terms that you have to understand are these 3 areas, and I'll go over why they are called anti-CTLA-4, which is the generic name is ipilimumab. It is made by Bristol Myers Squibb, and the trade name is Yervoy. There are actually 2 types of anti-PD-1, and those are nivolumab or pembrolizumab, made by Bristol Myers Squibb or Merck. But I'm going to use the term anti-PD-1 because they are the same drugs made by different companies. And then a new entry in the United States is so-called anti-PD-L1, and this is a new agent made by Genentech and Roche. But for the rest of this talk, I just want you to focus on anti-CTLA-4 and anti-PD-1, and I'll go over the evidence and how they are doing an astonishing job in treating a variety of human cancers. Now, in fact, the reason that this talk is revolutionary is that this strategy for cancer treatments of treating the immune system, not the cancer, is now been shown to be effective in all of the cancers shown on this slide, including common cancers such as lung cancer, colorectal cancer, hepatocellular cancer, breast cancer, and so forth. And I don't mean to imply that it works in every patient, because now we're learning how to select patients based upon immune criteria in order to select patients for different types of checkpoint inhibitors. But the remarkable thing is that whatever type of cancer you treat in your practice, including, say, head and neck cancers, that immune therapy may be part of your future practice, either before or after surgical treatment. Now, this is an important slide about mechanism so that you understand these terms that you may not have heard before between anti-CTLA-4 and anti-PD-1. So we now know that there are 2 mechanisms where a cancer can induce tolerance in our bodies. The first is it can induce tolerance in the central lymphoid tissue, in lymph nodes and spleen in our body. And this occurs when a dendritic cell or a macrophage, or what's sometimes called an antigen-presenting cell, brings tumor antigen from dying cancer cells elsewhere in the body into the central lymphoid tissue and comes in contact with a so-called virgin or uncommitted T lymphocyte. Now, ordinarily, this antigen-presenting cell will bind to an uncommitted T lymphocyte through a variety of receptors or ligands and send signals to tell this T cell to differentiate or to become a cytotoxic T lymphocyte or a suppressor cell that will actually dampen an immune response. So, for example, if a dendritic cell brings a protein from normal colon to these lymphoid cells, that can induce tolerance so that the immune system won't recognize ourselves as a foreign invader. Or if it brings a virus to uncommitted lymphocytes, it will induce a cytotoxic response to kill the viruses. And it should, in all of us, induce an immune response to recognize and kill cancer as a foreign invader. But if the cancer cells that have survived can induce tolerance, they then become masked so they're not recognized as a foreign invader. And we know the mechanism for doing that in the central lymphoid tissue is when there is a signal from the dendritic cell, shown here, binding to the receptor, which is anti-CTLA-4 on the T lymphocyte, it then causes this cell to be programmed or differentiate into becoming a suppressor cell and not a cytotoxic lymphocyte. So you can understand if we now have an antibody that comes to this point called anti-CTLA-4, it blocks the signaling pathway so that the only signals that this T lymphocyte can have is to become a cytotoxic lymphocyte against tumor antigens in an individual patient. So what happens then is this committed T lymphocyte and an army of T lymphocytes like it coming out of the central lymphoid tissue. The lymph nodes and spleen circulate all through our body, including in the brain, looking for any foreign invaders of a cancer cell. When it identifies that in the periphery, say in the lung or in the brain or in the liver, it then comes in contact with that tumor cell and starts a process of identifying whether that cell it's in contact with is a foreign invader or self-antigen. If it recognizes, so this is in the right-hand panel, through a series of bindings of the committed T lymphocyte to the tumor cell. Now we're talking in the periphery, in the tumor microenvironment. If it recognizes a foreign invader, it eliminates it, and we never see these individuals as cancer patients. However, the tumor cells that have survived have learned to send a signal to this T lymphocyte that I am not a foreign substance, I'm the same as the normal cells around me, and don't kill me, but leave me alone. And we know the mechanism for sending that signal to induce tolerance in the periphery between the tumor cell and the T lymphocyte is this signaling pathway between PD-1 on the T lymphocyte with its counterpart receptor on the tumor cell called PD-L1. Now, PD is programmed death, and PD-L1 or PD-L2 is programmed death on the to the lymphocyte that causes the lymphocyte to induce tolerance and not recognize or reject it. So again, we have the tools now with anti-PD-1 to block this signaling pathway between the committed T lymphocyte and the tumor cell. So when we block this signaling pathway, the T cell recognizes the cancer as a foreign invader and mounts a standard rejection response just the same as if it was a skin graft, a kidney graft, a virus, parasite, or a fungus. And these are the types of agents that we can use. So my point is, just in summary, is anti-CTLA-4 blocks the tolerance mechanism in the central lymphoid tissue, and anti-PD-1 blocks tolerance in the periphery between the committed or activated T lymphocyte and the tumor. So these differences are important as I go into the next series of clinical trials using these different agents and why they may be used as single agents or in combination.